Hi guys, in this lecture we're going to talk about circulatory assist devices. And the two big ones that we're going to talk about and that you're most likely going to see in an ICU setting is going to be the intra-aortic balloon pump and the ventricular assist device. So I'm going to talk about both of these in this lecture and hopefully they'll make a little bit more sense when I'm done. So circulatory assist devices. So with these, we have these things called mechanical circulatory assist devices or CADs, not to be confused with coronary artery disease, okay? We're talking about specifically these devices. These are going to be used to help decrease cardiac work and improve organ perfusion in patients with heart failure when like your conventional drug therapy is no longer adequate. So when we've got patients and we're working really, really hard on the pharmacologic side and they're just not responding to it anymore, now we need to start looking at, can we use something mechanical to improve their cardiac output, improve their blood pressure as well. So as I said, the two circulatory assist devices that we most commonly see are going to be the balloon pump and the ventricular assist device. Now, the type of device used is going to depend on the extent and the nature of the heart problem. So they usually provide interim support in three different types of situations. So one, the left, the right, or both ventricles require support while recovering from an acute injury. So like a post-cardio, what am I trying to say here? Post-cardiotomy, for example, like where they open up the chest. Another one that we would use it for is a patient needs to be stabilized before surgical repair of the heart. So let's say that patient had, a ruptured aorta or something like that. It would be able to stabilize them before they had their surgical repair. And the third type or the third condition would be that the heart has failed, like both biventricular failure that we're dealing with, and the patient is awaiting a heart transplantation. So sometimes we call that a bridging to transplant. So all of these coronary artery devices, they decrease cardiac workload and they increase myocardial perfusion. And in the side of that, they also augment circulation so that they can bypass the heart until we can get the patient either surgically repaired or get a transplant like we need it. All right, so let's talk about the intra-aortic balloon pump first. So the balloon pump provides temporary circulatory assistance to the sick heart, because that's, what it is, a sick heart, by reducing afterload, by reducing the systolic pressure, and augmenting the aortic diastolic pressure. And this is going to result in an improved coronary blood flow. So when would be some reasons why we would use this? Well, this would be great for like unstable angina that drugs have failed with. It can be used for a short-term bridge to a heart transplantation. It could be following an acute myocardial infarction, specifically if we're talking about like septal defects, cardiogenic shock, refractory chest pain that just isn't getting any better. We could use this preoperative, intraoperatively, or postoperative for cardiac surgery. And you see this a lot of times when you have patients when they have open heart surgery. Or any high-risk interventional cardiology procedure would be beneficial for this patient. So there are a lot of benefits to this. There are some contraindications as well. You can't use it on anybody with irreversible brain damage. You can't do this with anybody with major coagulopathy issues, so like DIC, for example. You can't use this on anybody with terminal or untreated diseases. Absolutely can't do it for abdominal aortic aneurysms or thoracic aneurysms. You also cannot do this for people with generalized peripheral vascular disease. So there are contraindications to it. The other thing that's important to note is that this is temporary use only. This is, again, it's a bridge to something bigger. All right, so what happens here? So the aortic balloon pump basically is like a sausage-shaped balloon, and it's a pump that inflates and deflates the balloon, and there's a control panel for synchronizing the balloon inflation to the cardiac cycle with some fail-safe features. So basically what it does is this pump is going to inflate and deflate a balloon to establish the diastole and the systole that we need in order for the heart to perform effectively. And so right here what I've got is this is the actual machine that you would see. And this is usually right there at the bedside in the ICU, and this is what you're going to see if you have a patient that is actually on the balloon pump themselves. So with this, sorry about that. So what you're going to see is how it's inserted. It's going to be inserted percutaneously or surgically into the femoral artery, and it is moved toward the heart and placed in the descending thoracic aorta just below the left subclavian artery and above those renal arteries. And then after placement, just like almost everything else, we're going to confirm placement with an X-ray to confirm the position. Then you have a pneumatic device that fills the balloon with helium at the start of diastole, and it deflates just before the next systolic contraction. The ECG is going to be the trigger used to start the deflation on the upstroke of the R wave. And I don't expect you guys to know this stuff, okay? This is all stuff that is going to be something you will see if you do end up working in an ICU. But here it is. You can kind of see that sausage balloon, you know, that you can see here. You can see it in the deflated position, and then you can see it going into the inflated position. And again, your ECG is what triggers this thing to inflate and deflate. And so again, what it's watching for is it's going to watch for that R wave for deflation, and it's going to inflate on that T wave when we've got ventricular relaxation. Okay, and that's what you're going to use when you see this actually working on your ICU patients. And then this is what the timing actually looks like. So just like I said, it's going to read the ECG. It's going to do things called counterpulsation. This balloon therapy is known as counterpulsation because the timing of the balloon is opposite to ventricular contraction. So again, you would always think that you would want it to inflate opposite of what it is. But in fact, it's usually opposite of your ventricular contractions. Excuse me. All right, so I'm not necessarily overly concerned with whether you guys understand the mechanics behind the pump, but I do want you to understand more of the nursing stuff, and that includes the complications of therapy. So vascular injuries like dislodgement of a plaque, you can get aortic dissection, and compromised distal circulation. Those are going to be your common problems with balloon pumps. So thrombus, embolus formation, of course, they add to the risk of circulatory compromise to the extremity. Because remember, we're going through that femoral artery, so there's always a chance that you can have decreased circulation to your distal pulses. The action of the balloon pump can also destroy platelets and cause thrombocytopenia. Movement of the balloon can block the left subclavian, the renal, or the mesenteric arteries, and this can result in weak or even absent radial pulses, decreased urinary output, and reduced or even absent bowel sounds. So patients that are receiving balloon pump therapy are also prone to infection. So it could be local, it could also be systemic, and if you have any type of infection, those require catheter removal. So to reduce these complications, it's very important for the nurse to perform cardiovascular, neurovascular, and hemodynamic assessments minimum of 60 minutes. But most of the time, these patients, especially if they're brand new out of surgery, we should be doing assessments every 15 minutes. And it's going to depend on your patient's, hemodynamic status. Are they hemodynamically stable? If they're stable, you can stretch it out more to 60 minutes. If they're unstable, definitely 15 minutes would be good for you to watch your patient. All right, mechanical complications are very, very rare, but they can occur. So you can have improper timing of the balloon inflation, which can cause increased afterload, decreased cardiac output, myocardial ischemia, and even increased myocardial oxygen demand. These complications, it's really important that they're recognized immediately and we report them to the healthcare provider as soon as we assume that something is going wrong. If the balloon develops a leak, the pump will automatically stop. Okay, the catheter is promptly removed to avoid an embolus, and signs of a leak would include things like less effective augmentation of the balloon, repeated alarms for gas loss, and blood backing up into the catheter. You can also get the malfunction of the balloon or the console itself, which would trigger a fail-safe alarm, and it automatically will shut down the unit. So these machines are built for those safety devices in need. All right. So the patient with an aortic balloon pump is relatively immobile. limited to side lying or supine positions with the head of the bed elevated less than 45 degrees. And that is really important because that tend to be a question I tend to see pop up when you do get questions about a balloon pump, is usually on the positioning of the patient. So make sure you make special note of that. The patient may also be receiving ventilatory support, which will likely have multiple invasive lines. All of this is going to increase the challenge of comfortable positioning as well as the risk for skin impairment. So the patient may experience sleeplessness and even anxiety. So sometimes you will provide sedation. We want to make sure that we provide adequate pain relief, skin care, and employ those comfort measures as often as we can. So as the patient improves, circulatory support provided by the balloon pump is going to be gradually reduced. So weaning is what we actually call it when we're getting them off of the balloon. We also use that term when we're getting them off of the vent. You'll hear them called weaning. And weaning involves reducing the balloon pump assist ratio from a 1:1 to a 1:2 and assessing the patient's response. If the patient remains stable, the ratio can be changed from a 1:2 to a 1:3. And until the balloon pump catheter is removed. Pumping is going to be continued until the line is removed, even if the patient is stable. And that's going to reduce the risk of clot formation around the catheter. All right, so I'm going to go ahead and stop this lecture here, and I'm going to do a whole separate one for the ventricular assist devices.